Cervicitis is again the tip of the iceberg. It's one of our biggest problems. I go to the CDC and I talk to them, and they say there's no data, but they include it in they talk about gonorrhea and chlamydia. There's a special section on cervicitis because it's very, very, very important. Mainly because we don't have good diagnostic criteria. They go untreated. And what cervicitis is really the beginning of PID, and I don't like the term PID, and we'll go through that. It's very, very common. All of the ones of you do surgery out there, you get your reports back from your pathology after hysterectomy, and you always see chronic cervicitis and on your slide, and you wonder what that is. And unfortunately, it's something we don't diagnose very, very often, but a third to a half of the time, it's an infection. It's a chronic infection, and if you're operating through that infected field, or you have patients that you're doing an endometrial biopsy on or putting an IED in, you're really putting them at risk. They're young, they're healthy, the risk overall is low, but it's still an unnecessary risk. Cervicitis, again, vaginitis we talked about this morning, is a nuisance. It's the vagina is an important part of the body, and you don't want it to be infected and have problems. But long-term cervicitis is just the lead to the next step. The problem is the government has certain things they have to do. They look at STDs. They look at STDs as gonorrhea and chlamydia because they have a test for them. It's easy to track, and they're rewarded and they're judged on how well they do based on how the country's doing with their rates of STDs. They know after years and years of improvement with STDs, it's starting to get worse, and they know they have to redouble their efforts. HIV, herpes, HPV, because they alter the cervix, may increase your risk of infection. Now, not all cervicitis is an infection. There's irritation. Again, they'll talk about douches. I don't believe that douches are a problem, but if you're douching with Clorox or something horrible, it can be, and people do strange things. The forgotten tampon, you know all about. And there's some allergens, especially there's lots of vaginal products, even KY, which is a very safe company, and we did the research with their personal products division. They have all kinds of new KY stuff, but that means there's all kinds of new chemicals in there, and some patients don't react well to chemicals. So there's allergic and there's inflammatory. And again, the first symptom for a patient is they say they have a vaginal discharge, but they could have some bleeding, they could have some itching, pain during intercourse, some bleeding or spotting. All these, are minor irritation nuisance. But when a patient brings that out, I automatically add cervicitis to my differential, and I think about it. I'm not going to do a CT scan or an MRI, but I will do a pelvic exam. I will put a speculum, and I will look at the cervix, and I will do a pH. Again, the ones that you see very easily, you're going to do your annual Pap exam. You put your speculum in. There's pus on the cervix. Patient has an odor. You ask them if they had a discharge recently. He said, "Oh yeah, I've got a little discharge. Or I noticed some discharge in my underwear." She's not complaining about it, but think cervicitis. And again, it gets worse. They start saying they have fever, nausea, abdominal pain. It's a problem. Okay. Again, the cervix, it's the entry to the uterus and the fallopian tube. You can have a patient with failure normal anatomy, but eventually, if it's untreated, can get worse. And I do the CREOG exams, and for the board exams, do a couple of questions for infectious diseases. If you're taking your board exams, they're always about cervicitis, undiagnosed, untreated cervicitis, because if you don't treat a cervicitis, it could get really bad. You see a discharge, automatically you need to do a workup, okay? Okay, PID is a bad term, and it's really an overlapping entity. The Infectious Disease Society, we changed that term about 5-6 years ago. It's no longer PID, it's lower LGI, lower genital tract TI, LGTI, or upper genital tract infections, lower genital tract or upper genital tract. Lower genital tract is a cervicitis, and maybe an endometritis. You'll then get a salpingitis, urethritis, tuber-ovarian abscess, and a peritonitis. The patient has a little bit of pain, you see that, you do an exam, cervical motion tenderness, maybe a cervicitis. You do your bimanual exam, uterus is tender, you get an endometritis, or adnexa is tender, you get a salpingitis or an urethritis, you got a mass in the adnexa, you got a tuber-ovarian abscess, you push down the abdomen, you let go, they've got rebound, that's a peritonitis. You can kind of figure it out by your quick exam. For treatment, I break it down into two simple treatment areas. And one is if it's gonorrhea and chlamydia, which you will screen them all. The government says screen them all for gonorrhea and chlamydia. That's simple. What's likely is the most common cause is not gonorrhea and chlamydia. It's something that's non-gonococcal, non-chlamydia. That's the only thing you're testing for. And so there's additional organisms that have gonorrhea and chlamydia. So you treat the gonorrhea and chlamydia, it doesn't go away, or your gonorrhea and chlamydia comes back normal, but you saw that abnormal cervix. So now you're stuck again with the whole thing with the labs and everything else. You're stuck with, well, what is it? Okay. The cervicitis treatment, according to the CDC, is simple. If it's gonorrhea and chlamydia, you treat them according to gonorrhea and chlamydia. Ceftriaxone, cefixime are still good. Just last week, you may have heard some resistance being developed in the Far East. It doesn't mean it's resistant and yet, but the MIC values are going up, so that's a problem. If it's negative gonorrhea and chlamydia, the number one thing is microurea. We won't go into the male urethritis. Cervicitis is just a female version of male urethritis. There's a lot of research on male urethritis. It's easier to culture. The men have more symptoms because they're using the urethra more often than the cervix is being used daily. And so their symptoms are picked up earlier. And again, if you don't have gonorrhea and chlamydia and you see that, the thing is assume it's mycoplasma or ureaplasma. It's going to be that way 25 to 40% of the time. And you treat with azithromycin or doxycycline, not for 7 days, but for 10 to 14 days. If they have a positive whiff test, there's some anaerobes involved. You can get that in the cervix, not so much in the urethra, and I add metronidazole. So doxy and metronidazole. Diagnosis, you'll find it on your pap. Your pap will come back normal, no evidence of dysplasia. However, evidence of inflammation, moderate inflammation, severe inflammation, that's a cervicitis. You can't disregard it. Don't just file the pap, say pap's normal and file it away. That is going to haunt you forever and ever and ever if anything happens to that patient. Again, I don't teach here. I teach you how to, and work with you how to help your practice. I don't teach you for legal. Next week I do a lecture on top 10 infectious reasons people get sued, and I go through my cases for the last year, and I'm telling you, you go back, it's a pap smear, it's moderate inflammation, what do you do for it? It's a result, it's an abnormal result. The pathologist thought it was significant enough to tell you about it. How come you didn't think it was significant enough to work up? So work it up. Same thing, you're working somebody up for an ascus, you do a biopsy, the biopsy comes back, CIN1, CIN2, no evidence of dysplasia. However, chronic mild cervicitis, chronic cervicitis, acute cervicitis, you've got to take that patient back and work them up. Okay, you do your gonorrhea and chlamydia if they're at risk, and then if there's not, I still treat them with doxycycline, and then you get your next PAP would be okay. Wet prep, we talked about this morning. You do wet prep, you see white cells all over the place. It's either a vaginitis or cervicitis. It could be an endometritis. Okay, I had a woman last month. She's coming back on Friday. Very sad case. We won't go through the whole thing. She lost a baby, went through in vitro during the histosalpingogram, got a bad infection, has a chronic endometritis, and I took care of vaginitis, make sure she had a cervicitis, and when she has white cells in the vagina, I know they're coming from the endometrium, and the in vitro people won't put an embryo in there until I clear that up, and I'm doing some endometrial biopsies too. Whiff test, you have a whiff test, there's something going wrong in the vagina. If there's something wrong in the vagina, it could be the cervix. And again, you see white cells, rule out vaginitis. If you rule out a vaginitis, you look in there, she doesn't have a yeast infection, doesn't have a trichomonas infection. Remember, BV doesn't cause white cells for the most part, and we go through all the other vaginitis. It's a cervicitis, which will prove it otherwise. Okay? Again, CDC, two major diagnostic signs. You got a purulent or mucopurulent discharge. Purulent is more likely a bacterial infection. Mucopurulent's chlamydia or mycoplasma. Chlamydia and mycoplasmas are in the same category. They're molecules, they're intracellular. It takes a while for them to cause some irritation, inflammation, 3 weeks to 3 months, but the cervix looks a little different. You take your pap smear, you do a swab for your gonorrhea and chlamydia, they bleed. Some may just have ectropion, especially if they're on birth control pills, but they bleed. I start thinking about cervicitis. I'll look under the microscope, see a lot of white blood cells, continue my workup, or when I send the specimen off, I make sure I look to see if they said there's cervicitis. Again, with the CDC, it's mostly asymptomatic. They may have some, they say, gee, I've been doing fine, but maybe it's this birth control pill, but I'm spotting 2 days in the middle of the month. I say, is it after sexual intercourse? They said, yeah, it's only after sex. I look under the microscope, 10 white blood cells per high-powered field. I've got a cervicitis. Chlamydia and gonorrhea are the most common organisms when found, because they're the most common organisms when found, because those are the only ones we're looking for. And again, if I don't have a vaginitis and I have white cells in the cervix, it's indicator of cervical inflammation, but and it's got a high negative predictive value, means that if there's no white cells there, I'm pretty sure there's not going to be a cervicitis. Now, again, what the CDC does, they really have added this into the CDC guidelines for STDs, which is the number 2 most popular document that's sold at the CDCs, is the STD guidelines, because they're really important. They're standard of care, and they think this is important. But there's just not a lot of data on cervicitis, because we don't screen for much else after gonorrhea and chlamydia. A lot on urethritis. There's more in urethritis, and we won't go through that. It's in your handouts, but not a lot. So what they do is they mention go to specialists, talk about specialists a lot, because they have to include this data, but they don't have the evidence to make it mandatory. And so for the specialists, we say you see lots of white cells on your under cervix. It doesn't have to have a gram stain. You can see what the white cells are. Okay, you got a diagnosis of cervicitis. It's a low predictive value. Again, gonorrhea and chlamydia, is the one that's most likely going to be positive, but it's the only ones you're looking for. So it's not always, it's less than 50% of the time. So what's the cause? Gonorrhea and chlamydia, what is we're looking for? Trichomoniasis, you'll see. Herpes is a problem, but you can tell when you have herpes. You can see when you have herpes. But most of the time, because you're only culturing for gonorrhea and sometimes herpes, more than 50% of the time, you're not going to find an organism. So, and especially if they're over 30, again, unlikely. The organism that seems to be coming out is Mycoplasma genitalium. It seems to be associated with cervicitis. You'll hear about it associated with BV, but again, BV is just an abnormal vagina with lots of these organisms. So instead of having 100 per centimeter squared, you have 10,000 per centimeter squared. So if you're going to get a cervical infection, it's going to be with an organism that's there a lot. So mycoplasma looks like the problem. They're finding it in men. Okay? Again, because you don't know what it is, and it's the gonorrhea and chlamydia is negative, you treat them over and over and over and over again, and you don't know what's going on. You look for other things. You look for an abnormal vaginal floor, because that's what the organisms are going to be. You look to see if they have irritants. Again, I don't believe in the douching is a problem. And there's some idiopathic things that some people are going along and just freezing, doing cryo to it. You're not going to solve the problem. You're just damaging the cervix and going to have them infected. Now, the cervicitis, we don't know what it is. You can't figure out what it is, but it's still there. The thing you've always got to protect yourself, protect your patient about, and protect make sure you're protecting the patient about, is that it's really, whatever organism is there probably can get up and cause a problem in the endometrium and everything else. So it's really got to look for signs of PID. And you look for evidence of vaginitis, but otherwise, cervicitis, you look for that. The NAT, the nucleic acid test, we'll talk about later. You look for gonorrhea and chlamydia. You can check them for everything, but you see 10 white blood cells per high-powered field. It's gonorrhea and chlamydia if you culture for them, but it's not always there. Again, over and over again. Cervicitis is a problem. We can't find out what the answer it would be. If you find an STD, you treat it. But again, the prevalence of gonorrhea, if you don't get a result back, if your gonorrhea rate's high, you treat for it, but basically treat for chlamydia, mycoplasma type organisms. So you give your azithromycin, doxycycline, and you don't need to add the ceftriaxone unless you have a high gonorrhea rate. The average gonorrhea rate in your population, if you have an average private patient population, is about 0.5% or less. Trichomoniasis, again, we talked a lot about this later. There's some new tests out. You know how you can do your pap smear and get your gonorrhea test and chlamydia test. Just in the past year, again, since last year, is you can now check off for trichomonas. It's FDA approved. In the past, they could do it, but it wasn't FDA approved. Now it's FDA approved. Again, you can generally see it under wet prep, but if you don't have a microscope, it's a good test. Again, the Affirm is a good test. Again, treatment over and over again, azithromycin or doxycycline. And again, if your gonorrhea rate's high, treat for the gonorrhea. Persistent, so you treat them over and over and over again, okay? And again, mycoplasma genitalium, the reference is all at the CDC document. You need to treat them. The treatment for the mycoplasma genitalium is azithromycin or doxycycline. If they don't get better, Cipro seems to be another good agent. So first line, doxy and azithromycin. After that, it's Cipro. And if you don't clear them up after that, again, the CDC doesn't know what to do, but they know there's something wrong. You don't just say, you have chronic cervicitis, you're going to live like this, or you have to continue to find an answer, or you really should refer them out, because this patient has an infected cervix that at some point in time is going to be an infected endometrium, an infected uterus, and infected tube, and infected fallopian tube. Okay. The ones who seem that it's not so much persistence, recurrent, it goes away for a pap smear or two, then you see it back in your pap smear again. That's usually an STD. Again, you're less than 50% of the time it's going to be gonorrhea and chlamydia. It's most likely going to be a mycoplasma ureaplasma, mycoplasma genitalium. Make sure it's not BV. You need to evaluate the sex partners. I do see the males. Most people don't want to. It drives my dean crazy when he has all these males coming to our clinic and complaints from the women. You just need to say, your wife, you have cervicitis, you need to be checked up, because it's usually a urethritis from the male that's also a part of that. And they'll treat them. Just giving them chronic, what they're doing in the other room there, with the vitamin D. Just giving her doxycycline for a long period of time and over again is not going to be helpful. Okay? Again, reevaluate them every once in a while. Make sure you have them come back again. This is the CDC telling you. Check them out. Make sure they come back. Make sure it's gone. Okay? We've been over and over this. And follow up. Again, they tell you to have to follow up these patients. If symptoms persist, you need to check them out again. There's a high rate of reinfection for gonorrhea and chlamydia. If there was positive in 6 months, you don't wait another year for your yearly exam. She has cervicitis. You treat her gonorrhea and chlamydia. You don't wait a year. You wait 6 months, like with PID. If you treat them for outpatient PID, you have them come back in a week, something happens to them in 2-3 days, you're really in big trouble, because you're really supposed to see them 2-3 days later. So 3 to 6 months if they're positive, 3 to 6 months after treatment. Management of sex partners. They want you to manage their sex partners. You don't have to manage them yourself. You can refer them off, but they need to find out where they're getting it. Cervicitis is just, it's just a male urethritis. For them, you need to say, don't have sex for a week, okay, if they're going to do 7-day treatment. Expedited male partner treatment, you can give patient treatment to the partner. I generally don't unless I see them. I do have them come in my office and I culture them. But again, usually just refer them out. Urethritis, I only included the urethritis to show that there's very good data with urethritis. Cervicitis is just urethritis. They have lots of data on the men. Chlamydia is there 15 to 40% of the time, let's say 25% of the time. If you don't have gonorrhea and you don't have chlamydia, it's mycoplasma genitalium. We talked about the Affirm test for Trick, Candida, and Gardnerella. It doesn't test for mycoplasma genitalium. The new labs, the PCR labs, the Biopath, Bioreference, and MDL they have special tests now for cervicitis and urethritis. The problem is, again, we'll talk later about the insurance companies. The insurance companies are horrible. I have to give a deposition next week because one insurance company around Philadelphia, Blue Cross Blue Shield, has totally denied all the testing for cervicitis and vaginitis on a group of women because they say it's not important, which drives me crazy. And I'm going to go to court just to represent these women who an insurance company just says, this is not important, and denial, and so the patients have to pay out of pocket, and it's just wrong. It is a problem. Sure, the data is strong in men and not strong in women. It's just that we're not doing the research like we should. Adenoviruses are a problem. You're not going to be able to screen for adenoviruses. Again, uroplasma is important. And again, for urethritis, they want you to diagnose, but they've done the research, they know what it's like, and basically they have their treatment guidelines. Enteric bacteria, E. coli, the Klebsiella, that patient we had before, have been identified as an uncommon cause, but it's there. I see it in the vagina. If that's all it's in the vagina, that's what's going to infect their cervix when their cervix is infected. The treatment for males is like females. Again, just to show you that if you don't have an answer, and you won't have an answer for most women, it's zithromycin, doxycycline, and again, the quinolones are very, very good also. Again, diagnosis, you're going to not see a lot of your tricks. It's hard to see. And HSV2 has been associated with it. I send off my chlamydia, my herpes. It's not easy to do. But again, mycoplasma genitalium. I just want to show you over and over again. There's so much data. This is all from the CDC. It's all telling you about the urethritis. It's just males. Okay, so I wanted to go through that quickly. Just to bring up the point, cervicitis, and then get us right back a few minutes late on time. Cervicitis is important. What I do is I take the patients that I'm going to do any kind of procedure on. And again, the CDC guidelines previously said don't do anything on a woman unless you're certain their vagina and cervix are uninfected. Okay, they've backed off because of the lawsuits and the legality to say you don't have to screen everybody. But for me, I'm doing a procedure, whether it's an IUD, a endometrial biopsy, a hysterosalpingogram, a hysterectomy, ablation, tubal sterilization. Simple thing is they would do a pH first. If that pH is abnormal, okay, then then she doesn't have lacto, and I look at her vagina. She's got white cells, then I try to fit into a category. Is it white cells because she has a vaginitis? And if I don't see a yeast infection, and I don't see a trick infection, and I don't see her bad vaginitis, we talked about this morning, the whole thing about this morning, then she has a cervicitis and proven otherwise. She has symptoms, lower abdominal pain, friability, mucopurulent discharge, greater than 10 white cells in a high-powered field. She has a cervicitis, will prove otherwise. I will then treat her before I do the procedure. Now, the CDC just came out saying you can treat them while you do the procedure. If she's there for an IUD, you're allowed now to go ahead. The CDC says you can culture them, treat them, and then stick the IUD in. I generally tend to wait. She's got an infection. I'm just taking from lower genital tract to upper genital tract. The best example for you is, as you know, your hysterosalpingograms. How many times have you done a hysterosalpingogram, and all of a sudden, 4 to 5 days later, the patient has a rip-roaring infection? You've just taken the infection from the cervix, you've blown it into the endometrium, and then if her tubes are open, you've thrown it into her tubes and abdominal cavity, and they got really bad peritonitis. The guidelines now are if she was blocked and she's now no longer blocked, or you suspect there's a tubal infection, you got to prophylax them at the time of hysterosalpingogram, but it's all because of cervicitis. In Europe, it's a socialized medicine, so you have to be on a list to get a hysterectomy. It takes a few months. They screen everybody with a sample to the lab to check for cervicitis and vaginitis. If they come back with white blood cells, they all get a series of doxycycline before they get to their hysterectomy, and then they get a prophylaxis with a cephalosporin and/or metronidazole suppository at the time of surgery. It's again a small problem when it comes down to percentages. Probably 5% of your patients have this, but if you do any kind of procedure, it's going to double your risk. Sure, your risk of post-hysterectomy infection in your population is probably 5%. Same thing with hysterosalpingograms, endometrial biopsies, probably less than 1 to 2%, but it doubles the risk. So you can really help your patients a lot by just looking for abnormal pH. If the pH is abnormal, then I go ahead and do wet prep, look for white blood cells. If it's not a vaginitis and her cervix either has a kind of redness, irritation, some white blood cells or some mucopus or mucopurulent discharge, I go ahead and culture them, but I always treat them. So a very simple, small problem, but it's going to save you lots of headaches when it comes to the number of procedures and the things you do in the future. And there are signs. Again, don't disregard a pap smear with the white cells, inflammation on. Don't disregard an endometrial or endocervical biopsy, and definitely don't disregard an endometrial biopsy with inflammation on it. There's something there. We just don't have the capability in the laboratories to diagnose it yet.